This session about SNOMED and analytics is focusing specifically on postcoordination, the mythical beast. I'll probably take about 30 to 40 minutes to go through the slides and then again, like before, have some questions. So just an outline, last time we covered the bits in sort of dark grey, including how to do subsumption of pre-coordinated SNOMED codes. This session will look at postcoordination, which will necessarily involve reviewing subsumption. So what is postcoordination? It is supposed to be the solution to a fine mess in the right hands. And we'll dive further into that. Why do we need it? The approach of enumerating codes, having one code for everything and anything anybody wants to say or count, doesn't scale. And we can see that in the graph on the right hand side. The yellow line is SNOMED over the last 30 odd years. The red lines are read 2 at the bottom and CTB3 halfway up. And we can see that from all of them, the number of codes just continues to grow. There's never enough. People keep asking for more. We know that issuing new codes is both slow and expensive. There's about 10,000 new ones a year that I said last time. And in order to do that, there is a small army of very specialist terminology authors who do that. It used to be the case when SNOMED was released only twice a year that there could be a lead time of 9-10 months between asking for a code and it actually being created and released by us. With our revised release cycle of sort of 7 times a year or 13 times a year for drugs, the lead time is a little bit less, but the time between requesting and our releasing it is not the only problem. You also have to get the code to the clinical coalface. And in primary care, there is a lag of a couple of months, usually, between us releasing a code and it being incorporated into either of the 2 GP systems. In secondary care, the lag can be considerably longer, measured in years in some systems. So it's a very slow process. We know that even if we did attempt to issue a code for everything under the sun, it is impossible to correctly, manually organize and reorganize all those codes into a complete and reliable class hierarchy. And we also know that if you do put all the codes, all the subtle variations that people wish to record into one system, it can become very, very hard to find the code that you wanted, even if it exists. My poster child example of this is the codes for accidents involving a pedal cycle. This is a section from, I think, ICD 9, which was released in the early 1970s, so not quite 50 years ago. And at that point in time, there were just 8 codes in ICD for recording an accident involving a pedal cycle, and you can see them towards the bottom. Although the last 2 are kind of catch-all dustbin categories of other kind of accident other than the ones for which there's a code already specified. But that didn't prove enough. By 2007, I suppose, over the following sort of 30, 40 years from ICD 9, the number grew in the terminologies. There were 81 codes in Read 2, 86 in Read 3, and 87 in SNOMED by the early 2000s. But that still wasn't enough. ICD 10 in 1999 had 587 different codes for an accident involving just a pedal cycle, and finding the right permutation in amongst all that lot can be quite complicated. And the reason that there's so many in ICD 10, or at least in one draft of ICD 10, is they ended up with the cross product of 10 things that you might hit: a pedestrian, a bicycle, a motorbike, a car, an HGV, a train, an unpowered vehicle, a tree, or something else other than the above. 5 roles for the injured person, 5 activities when they were injured, and 2 contexts, whether in traffic or not in traffic. And that ends up with things like the code at the bottom: pedal cyclist injured in collision with 2 or 3-wheeled motor vehicle, unspecified pedal cyclist, non-traffic accident while resting, sleeping, eating, or engaging in other vital activities. And so you've got 587 different codes, a bit like that one, and you have to find the right one. So this approach of just having more and more code doesn't work for a whole host of reasons. And so it has always been kind of the goal, the aspiration, to provide a means for people to assemble more detailed and expressive statements, not using one code, but a collection of codes. So a kit of parts makes what you want to say from some pieces, recombine the semantics that you want. And then the important part is, having made your expression of multiple codes, you then need to be able to organize that expression automatically on the fly by comparison with all other expressions that have been entered by anybody else, in order to say, when have two people actually said the same thing? They may have used slightly different codes to do so, but they basically mean exactly the same. Or when are two expressions are kind of each other, especially if one of those expressions is a data retrieval extraction specification expression, and you're trying to identify all the expressions that anybody might ever put into a record that are subtypes of the thing you're looking for in the query. So coordination doesn't mean expression building. It means organizing the expressions after they've been built. And that's a common misconception. Expression building, of course, is not a new idea, and those who are working with ICD and OPCS and so forth already met it. So ICD has, for nearly 50 years, had a dagger asterisk system where some of the more detailed clinical diagnoses can only be recorded as a set of more than one ICD code, one of which will typically be identified as the primary code, and one or more others as secondary or asterisk codes. And very often it's just a pair, a dagger and an asterisk code. But in some cases, like the bottom example, sort of halfway down the screen, intentional overdose by coproximol, can only really be accurately coded in ICD-10 using 4 different codes that collectively, in combination, mean what the single SNOMED code in blue says. So on the left-hand side, we've got some ICD encodings, and in blue, the SNOMED single pre-coordinated codes that exist in SNOMED that mean the same. On the right-hand side, we've got a Kaposi's sarcoma of lung example, which is an ICD-O coding of a topography code and a morphology code. And down the bottom, we've got OPCS4, which allows supplementary codes to be provided, that usually provide a little more anatomical precision to the target of the operation, but in some cases can provide quite a lot more detail. The very last one on the slide, there's a single SNOMED code, fluoroscopic arteriography of coronary arteries, ascending aorta and peripheral vessels. And the correct OPCS4 coding of that is a string of multiple OPCS4 codes. So is post-coordination just any kind of built multi-code expression? It's a bag of words and concept IDs. So here's an example of 7 SNOMED codes. Is it just that random set of codes? Well, no, because I can arrange those pieces, 7 of them, in the order shown on screen. So we've got some kind of clinical finding. The finding site is a tibia or part of the tibia. It's associated with a fracture, and the cause of evasion was a standard donkey. Okay, so this person's been kicked in the leg by a donkey and they've got a fracture. That's reasonably clear. But I can rearrange all the pieces because there's nothing in that original set of numbers at the top that says how they combine. So I can rearrange them in all sorts of ways that make no sense at all. So it's quite clear that just having the list of codes in much the same way that ICD and OPCS codings are provided isn't sufficient in the SNOMED context. There are rules to how things go together, otherwise you can create nonsense. And so in addition to just providing lots of codes, SNOMED also provides or dictates a fair number of rules as to how they can be structured together, and also provides a syntax for saying how they have been structured together to create a particular semantic expression. So is it just conceptual Lego, a giant box of bits and pieces? So here we've got an imaginary box of SNOMED Lego, and you can see they're different coloured pieces. So you can tell different sort of categories of SNOMED code. We've got in red some procedures and things. So the idea is you kind of combine these together in an animation, which hopefully will work over Teams. I can put together these pieces and I end up with destruction of a lesion in the kidney, all wrapped up in a procedure, and the approach, I can't read, was probably open on the right hand side. But that combination of pieces exists in SNOMED also as a pre-coordinated expression, and the pre-coordinated code 175924000 is identical in meaning to the collection or the expression of codes that I put together in that little building. And I can combine those codes into ever more complicated pieces. So here we've got the thing I originally made in the previous animation, but I've embedded that within something bigger. In this case, I've said there's some kind of situation going on involving an open destruction of the renal lesion. It's elective. It's been done in the past to the subject of the record and not somebody else. And all of that is encapsulated in one slightly bigger SNOMED post-coordinated expression. When do we post-coordinate? Well, the original use case, excuse me, the most obvious one was to add left and right, particularly to procedures. But that's closely followed by, in the case of diagnoses, to be able to say, is this a family history of the diagnosis or is it the patient that's got this diagnosis? Okay, if it's the family history, is it the maternal or the paternal history? For some diagnosis, there's also a question of a future goal, of a future state of not having something or having a particular clinical finding. That could be normal peak flow in an asthmatic would be a future goal. Or there's a risk of a clinical state in the future, an abnormal peak flow in an asthmatic, if there's a risk of that under certain circumstances. So how do I encapsulate risk of this, that, and the other? I don't really want to have to create an entirely parallel hierarchy in addition to the 90,000 diagnoses, another 90,000 risk of diagnosis codes. That makes very little sense. But the list of things that you might want to post-coordinate this way starts to grow quite quickly. If you're doing surgical procedures, you've got all these kind of surgical procedure life cycle states. You've got the approaches, you've got a whole bunch of other things. There's no end of adjectives and things that it would make more sense to be able to add as decorative items onto some core code, and that's kind of the goal of post-coordination. And so if we're going to do that, we need different kinds of ways of actually assembling our statements. We don't want to pick them from the sort of huge bicycle accident code lists. We need to be able to assemble them from user interfaces a bit like this, where you pick the pieces, and the pieces that are presented for picking make sense in the context of your starting point. So there's an intelligent interface that only brings up the useful or likely pieces. And with that kind of apparatus, in principle, you can make some really quite complicated expressions. So this dump out is some kind of clinical situation involving a procedure, and that procedure involves percutaneous access to a vegetation. I want to do some destruction of that vegetation. The vegetation's on the mitral valve. It's all elective. It's been performed to the subject of the record at some point in the past. Okay, so that's what we've ended up with. And we've got a syntax for laying out exactly how everything links together. And we can use that syntax with the human readable bit in the giant box in yellow, or at the bottom is exactly the same information serialized into a machine readable syntax with all the human readable stuff stripped out. So that's your expression building. But as I said, post-coordination is not about expression building. It's about how do I formally analyze any of these expressions by comparison with all other expressions in order to answer the question, what is equal to what and what is a subtype of what? Which brings us back to the subsumption problem. So in the previous presentation, I kind of covered how the parent-child relationships that hold between the codes you get in SNOMED out of the box, what we call the pre-coordinated codes, those parent-child relationships are normally queried using something called a transitive closure table in order to answer the question, what is this subtype of what? But in the context of post-coordination, we can't build such a transitive closure table because there are, well, not an infinite number of expressions. It's probably finite, but it's very, very large. And so you're never going to get an exhaustive table of all possible expressions and the parent-child or ancestor-descendant relationships that hold. So in order to answer the question, is that at the top a subtype of that at the bottom? You're never going to get a table that tells you the answer. There's got to be another way to do that. So I won't tell you what that way is, other than to say it involves a runtime classifier, a description logic engine that does that comparison and will produce the answer. But that's a piece of kit that, although it's been around for 10, 20, 30 years or so, is not pervasively deployed anywhere really in the world in this environment. And it's why post-coordination, although SNOMED sort of aims to support it, it is not a common thing to do because in most cases there is no capability to do the analytics or analysis that is required to do the coordination part of post-coordination. What I want to move on to now, I think, is well, okay, so SNOMED in theory does post-coordination, but in practice, most people are not really in a situation where it would be a good idea to do it. But there is a cost to the fact that SNOMED is set up to do post-coordination that is perhaps hidden, and it's kind of the garbage in, garbage out problem. Even before SNOMED came on the scene, we knew that near patient coded data capture of clinical information was often of low quality. There is frequent missed coding where something which could be coded is not coded. And perhaps even more frequent miscoding, where things that are coded are in fact coded incorrectly. And there's quite a lot of inter-rater variability, different people choosing different codes to code pretty much the same clinical phenomena, and quite a lot of coding drift, where over time, although at any one point in time most people are coding broadly the same way, they're not coding broadly the same way compared with what they were doing 2 or 3 years ago. SNOMED CT, one of its goals, and post-coordination is part of the mechanism for doing this, and the other mechanism is the way that it classifies its own content. So these are both powerful techniques to help improve or provide new solutions to low data quality. But if you ignore those techniques and those properties of SNOMED and deploy it as though it were ICD especially, then one of the consequences is that coding quality can very easily nosedive. So this is the sting of the tail. In order to support post-coordination, there is going to be a very large number of codes and a very large number of kind of atomic basic pieces. There are effectively infinite combinations, probably more post-coordinated expressions than there are grains of sand on a beach. There are no expression building tools currently at large that I'm aware of, very little user training, and in many systems, no constraint over the coding choices that people can make. And all of this adds up to more ways for users to get it wrong. And we see this in data that we get from secondary care in particular, and to a lesser extent from primary care. So here are some obvious miscode examples. So on the left-hand side, we've got some numbers. These are taken from a data set involving, I think, 900,000 sequential attendances at one A&E department, where each attendance was given a SNOMED code to say why they had arrived. And you can kind of see what was intended. Okay, so we've got just over 1,000 people with a temperature, or 145 more specifically with a high temperature. 118 with an FB, which is probably foreign body, 24 with TB, probably tuberculosis, 33 with a spot, 15 with an MI, probably myocardial infarction was intended, 17 drug users, I guess, 8 drugs, same thing, 373 alcohol intake, so I guess they're saying they're drunk on arrival, another 207 probably also drunk, 117 different turn of phrase, but probably also drunk, 50 drunk, 33 with a lymph node, I presume that means an enlarged lymph node. 136, something to do with the nasogastric tube. 16 AAAs, which I think in this context probably meant an abdominal aortic aneurysm. 535 RTAs, that's probably the standard abbreviation for a road traffic accident. 396 psychiatric. 230 stabbings. Okay, that sort of seems plausible. But what they'd actually coded this lot to is on the right-hand side. So although the first two temperatures are supposed to be clinical findings, the codes they've chosen are neither. One of them is high temperature, the second one, high temperature as a physical force, as distinct from high pressure, coldness. So it's not the clinical finding of pyrexia. If you ask for patients with pyrexia, you won't get any of these. The FB code, that means foreign body, we suspect in the context in which it's used, is actually an abbreviation for the idea of being followed by something. Similarly, TB transmitted by. The one in red spot, well, that's a common name for the fish on the right-hand side, which is a freshwater fish from the eastern seaboard of the United States, called a spot because of the black spot on the side of it. And so on down the list. So essentially, none of those codes, none of the statements on the left were coded to the right kind of thing. All the patients who were drunk were coded to the notion of some kind of alcohol. And note that alcohol in SNOMED is the common grouper of all alcohols, not just drinkable ethyl alcohol, but also drugs like propranolol, which are alcohols. So the word alcohol in SNOMED does not mean what many people would assume it to mean. Another one at the bottom in red, the AAA example, they picked the abbreviation AAA, which in fact in SNOMED is associated with a brand name for a pharmaceutical manufacturer that only make one product, which is an anesthetic throat spray. So completely miscoded, and that's obviously quite a serious diagnosis. Next one down, the RTA road traffic accident had been coded to renal tubular acidosis, which is highly unlikely to be what they meant, especially not in those numbers, but unfortunately shares the same acronym RTA. And in the SNOMED system that they were using, they could pick the description RTA without ever seeing what it actually unpacked to, and in all of these cases had picked something completely different. Yes, a disorder, and yes, a very serious one, but not an RTA in the sense of a road traffic accident. So that's a very serious miscode. And they were unaware of this in this trust, that this was going on. More example from the same place, but about 10 years after they were advised of the problems on the previous slide, nothing really had changed. They were still recording this freshwater fish. They were recording all manner of skin diseases as moles and birds and so forth. So these are all supposed to be diagnoses, but they basically picked codes from the organism hierarchy of SNOMED. So very simple category error. You're trying to record a clinical finding and the clinical system's letting you choose an organism. And there's nothing to stop you putting wildly stupid things in. And that's the state of play at the moment.